My name is Leah Bright. This is Josh Schechter. And this is one of a talk that we love to give together. We're from different institutions, but we actually train together. And I think all of us know that when you train together, you're family. So he's stuck with me for the rest of his life, poor man. This is one of our talks on how to be an amazing bedside teacher in a very busy ER. Both of us at this time are working in very large inner city hospitals, and we are all faced with very busy EDs and how to integrate teaching, which is not always easy when you're really just trying to make sure that there's no fires that you need to be putting out. So this talk actually originated from the residents, and we took a poll of our residents and got pearls and feedback from them on how they want to be taught, because they always tell us they're not being taught. You're not teaching me, you're not teaching me. And they can go through like 10 things you taught them. And like, oh, I guess I forgot about that. So ask your residents next time after shift what they learned. The answer always is, I'm like, we talked about this, we talked about this, and we talked about this. Oh yeah, we did. So just reinforce that you are teaching. So our outline today is the challenges of teaching, the literature behind us teaching in the busy environment that we're working in, and how to adapt to our new and changing environments of our busier and busier ERs, and then, of course, a conclusion.
And I'm sure we've all felt like this at some point. You know, the stretchers are stacked up down the hallway. You got 35 people coming up to you, how angry they are. They've been waiting 7 minutes to be seen. And in that environment, it's really hard to kind of motivate yourself to actually teach, whether it's a medical student or resident. You kind of just want to go on, move on to the next patient. But it's a really great time. You can actually get some great learning in, but using slightly different techniques than maybe talking for 25 minutes about a specific topic, because that's not going to happen in this environment.
Does anybody get one of these? My chair's here. This is my report card. I get this email every once in a while, lets me know how slow I am and how behind the pack I am, and I'm not going fast enough, and I'm the slowest person to get my urine sent off to the lab, and the very bottom is my Press-Ganey scores, just in case I was wondering how I was really doing. They're all zeros. I'm not sure what that means. My patients are just like, yeah, she's not even worth turning in a Press-Ganey on. So I look at this, and I do try to make adjustments, but I do find it stressful, because I do understand that we are under metrics, and they're not like something that everybody just made up. They're under CMS, they're coming from a higher place, much higher pay grade than me, and I have to be part of the team. I have to figure out how to help my team, yet at the same time be an academic physician. Yes, it's over a year old. I won't put my new one up. It's even worse. So our challenges are our metrics, right? We can't sit and pontificate. It'd be great if we could see 5 patients, during an 8-hour shift, but that's just not going to happen. And also, literature shows us our confidence and our knowledge is actually one of the biggest barriers to teaching, is our residents are hungry, but they also like to question us. And then how to teach in a limited environment. So our teachers make a lot of decisions, and they've actually shown that the more senior you get in your career, the less teaching you do, because you're more able to recognize the algorithms and the patterns of your sick patients. And it takes a lot more energy to stop and teach and slow down than it does to actually just keep moving.
As you can imagine, there's not a lot of literature on education in the emergency department, too much in terms of bedside or clinical teaching, but there is a little bit out there. This is an interesting study from 2000 from Annals. Now, it goes into the problem of overcrowding, why is there overcrowding, and what happens because of overcrowding. And I know we've probably fixed the problem in the last 18 years, but maybe not, right? And I think overcrowding has become just a bigger and bigger problem that we are seeing every single day. And what's interesting about this study is that just one of the things that they realize that goes first is teaching. And not only teaching, but the mission of teaching at that institution. So it's not just the teaching, but actually the mission kind of falls by the wayside. Because if everybody's just working, it's hard to really create an environment and a culture of teaching. And this is some literature from kind of the internal medicine folks, and this is really just actually bedside teaching, going to the bedside, and how it's kind of a lost science. It doesn't happen as much as it used to. And what's interesting, what I kind of took away from this study, is that they actually found that learners who got bedside teaching did a better job at diagnosing, and they actually improved their test scores, which was kind of interesting. It's not like the best of studies, but it does kind of give you an indication that maybe there is a benefit to actually going to the bedside, interacting with your learner and your patient at the same time. This is from the emergency medicine literature, and this is really interesting in that they went to a place and they surveyed the faculty, they surveyed the residents, and they said, who is your best clinical teachers? And what they did was they picked 4 and they followed them around to see what techniques they used in the clinical area. And I'm not going to go through the whole list of different things, but what was interesting was that the most used techniques were really just engaging that resident, asking questions, doing follow-ups, giving just some advice, as simple as advice, rather than giving like a whole long talk on whatever specific topic. And this is not really a study per se, but it's really from academic emergency medicine with a whole bunch of different techniques that you can use in the busy clinical area, some of which we're going to talk about later in this talk.
So the challenge again is that sometimes you can have a slower shift and sometimes you have a busier shift, but trying to figure out in the chaos where you can find those moments to teach. And I find it very tough sometimes when I feel like as an attending I'm putting out more fires that have nothing to do with medicine, and trying to find that moment to stop and actually breathe. Because we always say, our residents always say, well, I can't do this, I don't have enough time. Well, that's sometimes how we feel. You know, I can't stop and slow down because I don't have enough time. So,
first thing you do before you kind of decide you want to teach, first you have to decide you want to teach, but know your environment. The cardiac arrest, probably not the best time to start doing aggressive teaching. I've actually seen attendings pimping medical students while they were doing compressions. That's probably not going to be so effective to say, oh, what are the H's and T's? What do you think is going on? And they're just doing this. And it's really not, they're not going to get so much out of it. The patient might actually suffer because the resuscitation might actually suffer. So know where you're teaching and what you're teaching, and know that your environment. That's really important. You also have to know your learner, right? You're not going to do the same things for the medical student as you would for the student to graduate resident. If you're discussing the differential of chest pain with a medical student, that's great. But if you need to discuss with a resident who's graduating in a month the differential for chest pain, there's something wrong with you or there's something really wrong with that resident, right? And prepare your learner, prime them. It seems kind of a silly thing, but you know, in the busy clinical area, you have a resident, they're thinking about giving the medications to patient in room 2, they're thinking about following the results on the patient in room 4, they're thinking about doing the pelvic exam of the patient in 7. They're not thinking about learning, so by just saying the simple words, hey, I'm going to teach you something now, you're priming them and getting them ready to go.
So there's a couple of methods that we like to use, and I actually will default to these in a busy environment when I'm tired, when we're hearing about 5 new patients, and this is when I'm going, as the resident's telling me, and I'm trying to pick out stuff, and I'm thinking I need to get in the room, I need to see the patient, I need to make sure that something crazy is not going on in there, and I stop and I actually start asking them, okay, so what do you think is serious about the situation or about your differential? What's probable, what's really happening? What's interesting, let's talk about the possible differentials, and then what's treatable. What can I actually address here in the emergency room? And no, I do not want to do another MRI for neurosurgery for the 15th time. So it's going through and figuring out what you can actually do at that moment, and it really takes like 5 minutes. And you have a little bit of discussion, and you say, that was really cool, I'm glad that we got to learn something. Again, reinforcing that to your learner that you weren't just asking them questions to being annoying, that you're actually trying to teach them how to think outside the box and how not to anchor. No, I've used rounds. So I also know how many people actually do rounding in their institution. And people do, like, I know we do, people do computer sign out. Right, so a lot of people, so we still round. We actually switched from computer sign out to rounding because we actually discovered that we were losing track of things that are happening to patients. Patients actually were were ill behind closed doors. I don't know about your has these closed doors. I can't see anything. It drives me crazy. So we're opening doors. We're seeing patients. We're actually going in and making sure they're still breathing. And it's actually helped us a lot. And I found at where I trained and where I am now that this method actually is really good for teaching. Now, it's uncomfortable for the team if you're questioning them in front of the whole entire team. So I try not to question or pimp in front of the team because I don't want this to be something that they dread. But I do try to say, what was important about this case, what was important about what we found out today, why the differential was X and now ended up being Y, and this is what we did to find out, and this is the evidence behind what we're doing. We're giving DD-AVP, this is why. We're giving desmopressin, this is why. So it was really good environment, and people tend to, on rounds, they pay more attention. I found computer rounds, my residents were kind of checked out, and they just kind of want to get done and get out of there. They know on rounds, they're stuck with me. They have no choice. Until I tell them they can go, they're my victims, and they're at my mercy. And then there's the 1-minute preceptor, and this is another thing where you also want to, again, tell the resident, we're going to do some teaching. So don't think that you're just asking random questions about the patient, and get a commitment. I think one of the transitions for your more senior resident is getting them to commit to a diagnosis and a plan. That if they don't want to do that, they want to hedge, they want you to do it for them, and to tell them it's okay that they're wrong, if they're wrong with their plan, but they need to start committing. And then what is the evidence behind their decision making? Why are they doing this? What are their thoughts? What's the pros? What's the cons? And then, of course, giving giving the general principle behind what your diagnosis is and what you're using to come up with that. And then reinforce it, and then guidance for errors or omissions. So if you go into the room, the patient says to you, well, yes, I have abdominal pain, but doctor, why is it going into my back also? And coming out and explaining to your intern on why maybe sending the patient home with this pain and our blood pressure to 100/100 with a diagnosis of a stomach virus is not a good idea. Yes, that did happen. But just trying to use it as a positive reinforcement on recognizing those signs and symptoms and bringing the resident back in the room and having them learn how you recognized a life-threatening diagnosis.
So bring it to the bedside. And I kind of discussed earlier how actual bedside rounds can be really, really helpful in teaching at the bedside. But what happens is sometimes what you get to do is actually engage the patient in their actual care, so the patients really like it. You can actually save time this way, because by bringing everything to the bedside, including the presentation, you're getting the presentation, you're seeing the patient, you're doing it all at once. You're all going to see the patient anyway, so why not do the presentation, and then you get to do some education, you can do some modeling in terms of your interaction with the patient, you can do some physical exam teaching. So there's a lot of utility. So sometimes when a resident says, hey, I have this patient who starts presenting, I'll just get up and I'll be like, hey, let's just go to the bedside. It's as simple as that. You're going to go there anyway, so you just walk over there, and it actually might save you a little bit of time, because then you're doing everything all at once, and then you can move on to your next thing. You can do some teaching, and the patients don't get upset about this. They actually, there's a bunch of studies showing they appreciate it. They get to engage, they get to see that they're being taken care of, that people are thinking about them and people care about them, and that goes a long way. And also, there's not going to be a lot of wasted time because you're sitting there in front of the patient. So that's going to push you and the resident to really focus on the patient and what's going on with them. And you know what they say, give a man a fish and he'll eat for a day, teach a man to fish and he'll eat for a lifetime. So, and that's kind of the same thing here. So a resident will come, and a lot of times they'll be like, we decide we want to give antibiotics. And I'll be like, what antibiotics do you want to give? And they want to say like vancomycin or Zosyn. That's kind of like, they want to say it. But they know it's not right. Or both. People love to give that because that'll just cover everything. And so what I'll say is, well, why don't you spend a minute and a half and figure out what the right answer is? Sometimes I'll give them kind of like a push. I was like, why don't you look up the IDSA guidelines on this? Or sometimes I don't know the answer, and I'll just say, hey, let's find the answer together. And not only do I get to learn something out of it, but then I can kind of model how I figure out answers in a busy clinical environment. So we all get to learn. They get to learn the actual information, plus some how to actually practice in the emergency department and learn out of it.
So if you ever do delayed teaching, I find this method actually the residents really recognize it because it's taken out of the ER and it's at home and they get an email from me and they're like, uh-oh. And then they open it and it's actually me saying, here's the article we talked about. And I have like a few articles that I really love, and those are ones I will send out to them. And here's what we were talking about earlier. I thought you might want it. And it's just a really good way to follow up with them on a case if you discuss an article or you discussed a teaching point or guidelines, just to send it to them, because it reinforces your teaching, plus then they know they're being taught again. And it's also good to put your teaching point in your email. And when I ask my residents, like, who's a good teacher, a lot of time the feedback is so-and-so. And I'll say, why? Well, they always email me an article. Oh, okay, well, that's actually really easy. I can do that. So it's a really good way to take it out of the environment, make a note to yourself, because we're all tired when we get home. And I have like, archived articles on my computer, and I just send it out to my team and say, hey, this is what we were discussing. And I always get the feedback, thank you so much, Dr. Bright, really appreciate the article you sent me. They're hungry for information, and they're hungry for evidence-based information. And they really appreciate it. That's all I do on a whole shift sometimes. We're so slammed, or we're just getting killed with critical cares. They still recognize that I taught during the shift. I also like to use new studies. How many of your residents said to me, well, do you read the study that came out and said that we should be doing this, that, and the other? And you're like, uh-oh, what are you talking about? So what I always say is, okay, go get me the study. Let's talk about this. And if I have time, I'll go through the study with them in the ER and go through, is it a good study? Is it something that we should be adapting? Do we really want to give our patient this medication that the study came out yesterday about? And going through and teaching them how to critically appraise an article. And I also work with FEMA, so I'm not just doing it with my residents, I'm also doing it with my lovely medics who are super excited about lactated ringers and normal saline, and we're just like, oh, here we go again. And so it's just going through and saying we can't change a whole entire nation's protocols until you actually give me a good study. So it's very important to teach them to be critical and to be safe.
The debrief is a really great teaching opportunity. So the cardiac arrest, not a great time to start asking questions and doing the teaching. Then you're going to focus on the patient. But if you have a cardiac arrest, or you have a really bad case, or something goes really well, or something goes really badly, the debrief is a great opportunity to kind of do some teaching points, reinforce things that are done well, and correct actions that were done wrong. So actually discussing afterwards can be really helpful because they have something that they can kind of focus on, understand what just happened, and realize. And then, for your kind of early learners, whether it's medical students and interns, just going over some of the basics of what happened in the resuscitation can be really helpful because then they can say, okay, I learned these things and I have a patient to kind of associate it with, and that debrief can be really great, which, you can ask our simulation friends. They love the debrief.
So this is an example shift, and I will literally come into a shift and try to write down. I'm still old school from my old residency where we didn't have computers on wheels. And my little piece of paper with my patient list, and I'll actually write down like a little bit of ideas, so when I'm on my patient list, it reminds me to teach. And I'll put in little things, hey, at noon, try to do this. And hey, pull this article. Oh, we had an AFib patient, or I'll circle on like sign out rounds, AFib patient, pull this article. And it gives me like a little guideline throughout my day to try and remind me to teach. And I would literally look at my list and go, oh my gosh, I totally forgot that I had written that down. And it kind of helps me support me because my brain just checks out. And I'm trying to make sure that the intern is not killing anybody. And I want to make sure that everybody's safe and that, I have 1,000 patients in my waiting room that I'm worried about, but it also lets me check back in with my residents. So this is an example shift. This is very ambitious. But I try, and if I get half of this done, I'm really excited. Some days it just all goes to hell in a handbasket. None of it gets done. But I figure if I try a little bit, it makes a difference. And I do notice that when I do this, it really helps me because I can all of a sudden, I come on to a 7 a.m. shift, and all of a sudden it's 2:30, and I don't know where the time has gone.
Anybody have any questions or comments? No? Bueller? All right.
Does anyone know that? Yes, Dr. Kelly.
How would you suggest we deal with when the resident comes to us with non-palpable data, like Dr. Matus says, Dr. Winters says that we should be doing X.
The old I heard on EM Rap or...
You may not have heard it or don't subscribe, but so it's one thing if they give you an article, yeah, let's look at it. But they give you some general approach to something or other.
So I actually listened to EMRAT in these podcasts because I was getting that a lot, and we're kind of at that cusp, that generational cut, where we respond well still to that. Most of those, especially Amal, and they're actually going from articles. They will give you, during the podcast, they will reference their evidence. And the residents don't hear that, right? They hear the talk, but they don't hear the evidence. And so I'll say to them, that sounds awesome. Why don't you go back, listen to that podcast, and pull those papers? Because they're not making stuff up. They're actually pulling that talk from somewhere. So let me know what those papers are, and we can talk about it. And that challenges them. Because it also gives me a debrief or gives me like a little bit of a break so I can go listen to the podcast and figure out what they're talking about. Or I'll say, let's look up the evidence behind that. Give me the evidence, because Amal's not making that up. And it challenges them to realize that they can't just quote a podcast to me. They have to still give me the evidence, which they always ask from us. And I think that's a fair exchange.
Yeah, I mean, a lot of times, if it's something that I'm not familiar with, I'm honest. I'll be like, I haven't heard that. Let's go find this out together, or let me go read about that, and I'll get back to you. And that's a great way to do your delayed learning. But you get a lot of that Scott Weingart says, right? That's probably the biggest name who people are like, well, Scott Weingart says. It actually, no offense to Scott Weingart, but it bothers me to no end, because we're not about what somebody says on the end, but it's about like, what do we know? What do we know from what we've read? And sometimes it's a very reasonable opinion, and sometimes it's an opinion. And so sometimes that's a really great way to actually teach the residents about understanding what they're hearing online. And also a lot of times it's, well, Scott Weingart says this, but he says something very specific. And a lot of times he makes a very focused point, and the residents will generalize that, or the learners will generalize that to this. And so sometimes you have to be like, hey, that's what he said for this, but for this situation, that's not really going to be applicable, and this is the reasons why.
I actually really good case where one of my very smart residents wanted to give a lower dose of ketamine for pain, right? We're starting to do that more now. And he'd heard it, and I said, go get the article. And we read it, and we talked to our pharmacist, and we ended up doing it. So it's also an opportunity for me to learn, and then show him that I'm actually quite adaptable. I'm not that old. I can actually still do new things. But he was super excited to try it. The patient thought we walked on water. So it's really good to actually listen, because I've discovered in my old age, and yes, I'm old, that I've learned from my residents as much as they teach me, and I tell them that. So if they give me information I've never heard before, I'm like, this sounds really exciting. Let's talk about it, or let's learn about it. Go pull the article, go find it for me, as I want to hear about this. And that gets them really excited. So I don't know, what are you talking about? So.
I mean, yeah. I think most of the residents, in my experience, appreciate it, because then we get to really engage together, and they feel. And I think that's kind of the key here, is engaging with the residents. By taking it to the bedside, it shows the resident you're engaging. Now, obviously, not everything is for everybody, and one thing I've learned about interacting with residents is that they're always going to complain. Somebody's going to complain no matter what you do. You do A, they're going to complain. You do B, they're going to complain. You do C, they're going to complain. There's always going to be someone who doesn't like what you're doing. And I find that bedside teaching actually is really helpful. And I think it actually probably takes less time, but sometimes people feel like something takes more time because they're at the bedside. And that changing history is kind of like, that's what we deal with all the time. Residents get very upset about it. They get like insulted. They feel like they've done something wrong by the fact that the patient has said they have chest pain. Like, I swear they didn't have any chest pain. They told me they didn't have any chest pain. I asked 6 times to Sunday, and then I walk in there, well, you having any chest pain? Oh yeah, it hurts right over here. And then, that's just explaining to residents patience.
I've also found that bedside teaching tends to work a little bit better with the more senior residents. So my interns are already so overwhelmed and so freaked out, I'll have them talk to me, and then I'll go in the room with them, and then talk to the patient, and then walk out with the intern and say, okay, what did you learn? Because they're a little bit less confident. So if I'm trying to engage them, they'll get a little bit freaked out, because the last thing they want the patient to know is their lack of knowledge or lack of experience. And so, but the more senior residents, like my 4th years, we have a system where our 4th years run one side of our ER. I'll say, okay, let's go run our patients. And the 4th year and I will just walk in every room, and it's been very hard for me just to be quiet and not say anything and let my 4th year do exactly what I would be doing if I was taking the presentation from, or I'd heard about the patients from the more junior residents. So they like it. The 4th years really like it, and because they're getting a little freaked out now, they actually see that they're going to be responsible in 6 months. So it works really well with them then to walk out of the room and say, okay, what do you think? What do you think we should do? Do we feel okay with this plan?
It's also really great for physical exam findings, like the rash. Sometimes the resident will be like, well, the rash, it's kind of red, and maybe it's a little bit. I'll be like, let's just go there. let's do it. And then I'll help him describe it, explain what it is, what I think is going on. A lot of times, like, I don't know what that is, let's call it dermatology, or this person should follow up with dermatology, they're not sick. Or neuro findings or wounds, and it's really great for those things. You can actually model a good physical exam for the resident and also help explain what they're seeing in reality, as opposed to you going there and coming back and saying, hey, I think it looks like this. You can really just kind of say, this is this and this is that. So we've gone through some kind of techniques. These are not all the techniques that you could use, and you don't have to use every single one on a shift. But I think the key is it starts with you. And you have to be ready at the beginning of your shift to really engage your learner. And engaging the learner is really what's going to optimize any sort of teaching you do. Whether it's just a simple thing as asking questions as opposed to just hearing the presentations and telling them what to do, or just they say what to do and you say, yeah, fine, that's great, go do that. And engaging them, whether it's asking questions, giving advice, or just following up and seeing what's going on with the patient, that engagement is really important. And just preparing the learner, and simple things as, well, what do you think, what do you want to do, goes a very long way. And what did you learn today? What did you learn from that case? Thank you for listening.
And of course, because I'm from Hopkins, we had to put an Osler quote up. I didn't actually know he was from there when I first got there. I was like, oh, that's really cool. But we think it's great. This is a great quote on the study of medicine and how we've come to where we are today. Thank you, everybody.